So, my name is Sylvia Thun. I'm from Berlin. I work as a professor for digital medicine and interoperability at Charité, and I'm a researcher and a physician and an engineer. So, and I like to invite you to watch a TV series which is called Charité 2049. And there you can see the future of medicine, and the future of medicine is based on data. I think you will all agree with me. So what kind of data do we need? We need high quality data and high quality publications and clinical trials. And we know that we have more than 500,000 new publications in PubMed each year, and 50,000 substances at BfArM, where Stephanie is from, my former colleague. We have more than 160 organizations in Germany and more than 1,000 guidelines, clinical guidelines. And our newest project right now is digitalization of clinical guidelines with FHIR and SNOMED CT. What do we do? The metadata is based on IBM on FHIR, and my colleagues are right now in Dallas at the HL7 working group meeting, and the content of the guideline and the processes are in SNOMED CT. And I'm very proud of this new project. And everything what we are doing at Charité, it's a very, very huge hospital, is for our patients and our citizens. So, first of all, let's shortly look at our new strategy in Germany. And you all know that we are the country in Germany that doesn't really work with digital data in healthcare systems. We don't have an EHR yet, or just a small EHR from our insurance companies, and just 1% of our citizens are using the EHR, which is based on IGXTS, so paper-based PDFs and pictures, photos, and so on are within the EHR. And they all say this is the most expensive Dropbox in the world that we built in Germany. So, but things are changing, and you see all the laws, and we will have an opt-out EHR, which is based on FHIR next year, and we have this huge and good project which is called DIGA, which is a regulated regulation for new software vendors in Germany, digital applications. We have we can use secure cloud systems, and we will lift our telemedicine applications for more than 30%, because there was a limit in Germany. I don't know why there's a limit for telemedicine, but now with our new laws and our new Minister of Health, there is no limit anymore. So everything is going fine, and we will have pure interoperability in 2049, hopefully. And you all know it's not just about communication, and sometimes people say FHIR is just for communication and version 2. I'm an HL7 person. You will see it with my slides. I'm the chair of HL7 Germany as well. So, but it's the scientific question 7 years ago was for us, the research community, could we use FHIR as an architecture model, as a data model? And the answer is yes, sure. Big companies like AWS or Google Health work together with us, and they use FHIR as an architectural model. So, and this is our research we did, and this is what my talk is about, our Medical Informatics Initiative based on FHIR, SNOMED CT, and LOINC, and other codes. So you all know everything about interoperability, and perhaps some people don't know why HL7's name is HL7 and not HL8. 7 is the 7th level of the ISO OC framework, which is very old. So the application framework. This is the 7 and 7, and this is where we work together. And there's a close collaboration because people work together between LOINC and HL7, very, very old, and normal collaboration with SNOMED CT and HL7 people. So this is about people who talk with each other. And Daniel, for instance, he was a chair of the Term Info group at HL7 and SNOMED CT. So the collaboration is very, very important. Why? Because we just tried to map our cancer registry XML, which is proprietary, to SNOMED CT, and if you map it with FHIR and without FHIR, there's an 80% difference between the codes you have. So extremely different codes if you work with FHIR or map concepts with FHIR or without FHIR. So be aware, please, and try to teach your staff not only in SNOMED, but in SNOMED and FHIR, because it belongs together. There's a term info challenge. So the Joint Initiative Council is the umbrella organization that we built in Germany as well. So IHE, HL7, terminology organizations are working together since many years, and this is about people as well. And the new community who work within the 1 Million Genome Project and the Genome.de project, this is what we call it in Germany, are working together with the HL7 people and within the Global Alliance for Genomics and Health. And here the newest standard is the PhenoPacket standard. So everything what we are doing, and we convinced our minister to use FHIR, and to use not only FHIR, because FHIR is a 80-20 approach, you know everything about this, is based on the International Patient Summary. We did many, many years together here. We were in charge, some of the people who are here, of the master value set catalog with an EPSOS, and this is now this ISO standard. And so we tried to specify our work on top of the International Patient Summary, but the FHIR mapping was not there when we began 6 years ago. So it was a little bit of a challenge. So why does this work in Germany? Because we have something like the National Coordinator of Health in the US, and you know in the US you have the United States Core Data Set, UCDI, where you find allergies and conditions and rare disease codes and so on and so on. They have a value set authority, they have terminologies, and they have the FHIR core data sets. So these people are in charge here in Germany, together with 290 experts, to advise the Minister of Health. And I'm the chair of this group right now, and we have a huge roadmap. The roadmap is about content, like how do we build content for oncology records or for cardiology, and about technology. So and about politics and strategy. So who should be in charge of the value set authority in Germany? Should it be our national contact point, the Gematik, or should it be BfArM or other organizations? Because we are, Germany is very big, and many organizations think they are in charge of digitalization. So there had to be a strategy, and this is the roadmap. And now we do have a value set authority. Stephanie is in charge of our new value set authority, and we do have a strategy towards SNOMED. We are SNOMED countries since, I think, IN 5 years or 4 years. 4 years, and towards LOINC and ICD-10 and OPS. This is our procedure catalog. So you see, you first need to have a strategy and a political decision, and then you can really work very fast with the standards which are already in place, like IHE, XTS, for instance, DICOM standards, and we even mapped the DICOM metadata standards of pictures to SNOMED. So everything is in FHIR and SNOMED right now, and we are using Orphanet. I think Orphanet is a very, very important terminology which is included into SNOMED, yes, and but we have a special catalog which is called Alpha ID SE, but hopefully in the future it will be SNOMED then. So this is what we decided, and we decided beside that we should use for all use cases, public health, public surveillance, for research and for clinical use, FHIR-based standards. Yeah, like the US CDI. So we call it ESIC, and ESIC is the information standard for hospitals and for the electronic health record, which will be based on HL7 FHIR in the future, 2025, hopefully. I don't know if it's working because, yeah, it's a lot, many things are not ready yet here in Germany, especially on the level of our drug database. There's a lot of many things to do, and we are going towards IDMP as well, sure. And beside that, there was an organization in Germany responsible for these plans or these documents, yes, and they tried to translate the documents, old documents, to FHIR and SNOMED, and they failed. Yeah, they did it 3 years and they failed because behind a document there's always a process. Documents are very old and they didn't really change the content, and the content was not really semantically unambiguous. And this was the problem here with this approach. So right now we are going towards medication in Germany and the so-called core data sets in hospitals, ESIC, and you can find all data sets. They are sure open source. We can exchange them between countries and look at our base models, and we are doing this all the time because HL7 organizations are working together in Europe. Beside that, there was a pandemic and we created the so-called Corona consensus data set. These are 83 concepts, and all our researchers worked with these core concepts. And this failed as well because they really like to work with REDCap, and within REDCap and clinical trials you don't need to work with terminologies. So they didn't really want to have one core data set and then on top have their data that they needed. They wanted their own solutions because they wanted to work very fast and so on. And so, but Gecko was used within this European project, which is called Orchestra. This is connecting European cohorts to increase common and effective response to the SARS-CoV-2 pandemic. And within this huge EU project, Horizon project, they mapped everything to Gecko and SNOMED CT, and this didn't fail. So you see all the countries who provided data, and right now Orchestra is really successful. Beside that, there are many, many infrastructures that we are building, like one infrastructure for epidemiological and public health surveillance studies and clinical trials based on FHIR as well. There's a FHIR study resource, very interesting, in R6. If you are interested, you should look at R6. That's the newest version and not R4, because the research infrastructure resources are within R6. And here, infrastructures in Berlin or North Rhine-Westphalia, where we can just exchange PDFs and FHIR resources. And we failed with the FHIR part because it was a company from the US and the company from the US didn't really understand our German core fire resources, and we had to teach them to really implement our fire resources. And there is no use case. Why should we work within like 30 hospitals with fire resources? So perhaps you can tell me some use cases. And now we have 2 use cases, or just 1 use case for lab results and MRSA patients. So this is what we did. And this is the Medical Informatics Initiative, which didn't fail. And this is really, really successful because we are 34 university hospitals in Germany. We all work together. It's about collaboration, it's about sharing data, willing to share data, and we share data right now. And this is the interoperability working group, and they talked about syntactic standards 4 years, and since 2 years, they are aware that we should have value sets and that there's some SNOMED and LOINC and beside ICD-10. And so we try to find the first value sets here for our infrastructure in Germany. And it's about smoking habits and so on. So we have to work together with the scientific organizations here. And we have the agreement to work with HL7 fire, SNOMED and LOINC here within this research infrastructure. And we try to get the data out of our hospital information systems, which are very, very old. And at Charité, we have 350 different systems. So we take the data out of our systems and via ETL process, put it into our platform, and then we share the data with all other university hospitals. And it's about harmonization of data. It's about broad consent or no consent. It's about how can we measure data quality, and how can we do federated analysis? So we don't give the data away, just we do federated learning here. So, and this is our architecture based on FIRE R4 with data sets which are based on LOINC for vital data and lab data, and sometimes some value sets which are based on SNOMED as well are here included, especially on when you see the extension model microbiology. And you can see here the oncology module, which is the mapping from our old cancer registry XML to FIRE, or the pathology result, which is based on IHE Palm. And imaging, and there are now coming new models, PROMs, diagnostic reports, and so on. So we can really extend this model and this framework. And here you can see the condition, and within the condition you can see it's just a FIRE resource, and within the condition you can see the ICD-10 German modification, the Alpha ID SE for rare diseases, SNOMED CT, Orphanet, and ICDO. And we can extend it. And it's still compliant to the normal US core data set. So, and this is very important that we stay compliant with the international FIRE specification. So you can find everything on Simplifier and on GitHub. And here I brought to you 2 examples. One example is about our new OICAST microbiology concepts, which we applied for at SNOMED CT. And thank you that you helped us here. It's a very European code, the OICAST code. And the other one is about Probenart. It's about, you can just, as you can see here, just use SNOMED, or use these 3 codes in SNOMED, our value set, or try to use all descendants of a code set of a code. So this is what we did, and here you can see and find all specifications. How did we do it? We created implementation guides based on an existing standards. So this is not a new implementation guide, but the translation of the old IHE Palm work to FHIR. And the old Palm work was based on version 2. So we try to figure it out with our pathologists, how to really map this to FHIR. So the content here, you see all this free text is really right now in FHIR. The same with our, no, that's the molecular genetic findings, I'm sorry, that's even worse. So this is the pathology report. So, and then you can see this portal, and every citizen in Germany right now, not in Europe, when the EHS is coming, every citizen in Europe has the ability to work with this data. So this is the data that we have in our Medical Informatics portal, research portal, and you can just ask, give me all patients with C50 ICD code or SNOMED code who have a lab result of hemoglobin which is under 6 grams per deciliter, and please give me their biosamples as well. So first of all, you ask, is there data? And then it gives you back, yes, there is data, for instance, at Charité or in Cologne. And then you asked the Use and Access Committee at Charité or Cologne if you can get the data and the biosamples. And here, this is our feasibility query, and here you can just ask, and do they have HIV 1 and 2? And behind this, there is a line code and the EUCOM unit of measure. And this is extremely important. So you can say, okay, everything is there, and I use data from the US or OMOP or whatever, but OMOP or other data sets or frameworks don't have the precision. And we need precise data and precise queries here. And then we do have to publish our scientific work and the projects, same in the EHDS, so that you have to publish your work. And beside that, we worked on the phenopackets specification. This is now an ISO standard. So they try to work together, the HL7 community together with the bioinformatic community. And these are our projects, and our projects are all based on FHIR and those terminologies. You can see it's about devices, infrastructure, COVID-19 apps, and so on. And yeah, this is my takeaway message for you. We should all use FAIR principles and standards and try to reuse data, and so that we have maximum benefit, especially the patient, not we, the patient. And we should allow automatic processing, and there are huge projects going on based on structured and standardized FHIR data, which use AI on this data, especially at University Hospital Essen in Germany, and they have many, many publications. And coming back to the question, do we need in 2049 any standards, or do we just need some AI applications? And in my opinion, we need standards to have high quality AI results. Thank you.